Dr. Sarkar.
Thank you, Pooja. It was a nice demonstration of the case. Now I have just few questions. That is for discussions, just purpose. This was a 9-month child, I think, no?
Yes, sir.
So in 9-month child, if you get a mixing lesion, what is the commonest disease that you used to get in your hospitals? In 9 months, mixing lesions. It is very unusual case that you have showed us. So what was your mind when you are going to do the echo?
So we were thinking of maybe a TGA VSD. So that is the spectrum that we usually get, or a single ventricle with an unrestricted pulmonary blood flow, still operable, because this was a rare case. Yes.
Okay. Second question is just you teach us very simply what is the difference between a straddling and overriding for the audience. Very simply, you make us.
So these are usually defects that we find in involving when there's a VSD involving the inlet septum. Straddling is basically, it involves the subvalvular component, so that the chordae tendineae of the atrioventricular valves, if I take the right atrioventricular valve, like in this case, the tricuspid valve, the chordae, if they attach onto the crest of the interventricular septum, then that would be grade 1 straddling. If they go on and anomalously attach to the left ventricular side of the interventricular septum, then that would be grade 2 straddling. If they go on and attach to the free wall of the left ventricular septum, then that would be grade 3 straddling. And standard teaching is that grade 2 to 3 straddling makes surgical correction difficult, because a few of the chordae have to be sacrificed in order for the patch to be created and completely close the VSD. Overriding is basically when we talk about commitment of the atrioventricular valves. If there is more than 50% commitment of, say, the tricuspid valve to the left ventricle, then that would be a significant overriding, wherein the flow of blood is such, the streaming of blood is such that it goes from the right atrium to both the right ventricle and the left ventricle because of the override.
Okay, last question. How was you sure that this was a hyperkinetic PH?
So there were actually many pointers for that. First, the child had clinical features. The history was suggestive of increased pulmonary blood flow. There was a clear suck cycle. The child had failure to thrive. The weight was only 4 kg. Birth weight was 2.7 at 9 months. The child had not grown well. There was a hyperkinetic precordium. The X-ray had clear features of increased pulmonary blood flow. On echo, sir, we found that the VSG was predominantly right to left shunting. So since the RV was connected to the aorta and the LV was connected to the PA, so this was essentially a flow from the aortic side to the pulmonary side. So that is a feature of decreased PVR compared to the SVR. And there was increased pulmonary venous return. There was flow turbulence at the mitral valve inflow, and there was generous pulmonary venous returns, LA dilated.
Okay.
Can I put up a question for, in fact, both of you, and Professor Sarkar can also answer. How common is the double outlet right atrium, and how many case reports are there in the literature?
It's really uncommon. We have.
Pooja, did you do a literature search?
Yes, I did. So literature, there were a few case reports. So in our hospital, recently, we've handled another case. So we have, in fact, written in a series of 3 cases, one from the past, one I've been working here for the last 4 years, sir. We've seen 2 in the last 4 years.
Are you planning to publish it?
So we've sent in the report. It hasn't been published.
Okay. Congratulations. So, Professor Sarkar, shall we proceed to the second presenter?
Yes, certainly.
So, the second presenter is Dr. Rishika Mehta. She works in the Department of Pediatric Cardiology, Narayana Specialty Hospital, Howrah. So, over to Dr. Rishika.